Good afternoon to you, ladies and gentlemen. I'm O.P. Yadav, Editor-in-Chief of the Indian Journal of Thoracic and Cardiovascular Surgery and CEO of National Heart Institute in Delhi. It's my proud privilege to have Dr. David Berend, Chief of Cardiac Surgery at the Birmingham Children's Hospital from UK, visit us.
Thank you.
Welcome,
Pleasure
David.
to be here. Thank you for inviting me.
David is a pediatric cardiac surgeon and a leading light in complex congenital heart surgeries. And what I'm going to talk to you about is congenitally corrected transposition of great arteries. David, we all know that the natural history of CCTGA is pretty bad. Yet some of those patients surprisingly do so very well till adult life. So how do you identify those patients who you think would do well and you leave them alone, and who should be taken up for intervention?
So, you see, you asked the $64,000 question straight away. If we knew, then we know the answer. And that's the whole paradox of it.
Yeah.
It's a rare condition.
Yeah.
And yet, so even though we only see a handful of patients every year,
Yeah.
they're all different.
Yeah.
So you haven't got a single way of treating each patient.
Sure.
But as you say, as you rightly say, we know the natural history is very poor. And our eyes are turned by the case report that appears of the 80-year-old who survived a healthy life without any intervention. But they're incredibly rare. And it puts us off the truth, which is the vast majority of patients will get in trouble. So I think the first thing is we have to have a very low threshold for intervening on these patients. So pick them up early, and as soon as there's any sign of right ventricular dysfunction, that's their systemic ventricle, you should look to be intervening early in these patients.
Okay. And when you say intervene early, then what kind of intervention are we talking of? I mean, a double switch at the arterial level or at the atrial level? And how does that decision making take place?
Obviously, there are two very different groups of patients. There are those with outflow tract obstruction to the left ventricle, who are a bit like a fallow or a pulmonary atresia in terms of their physiology.
Yeah.
So depending how severe their outflow tract obstruction is, they can be quite cyanosed, and they're symptomatic from their cyanosis, and you manage them as you might any other child. And in a way, that is more straightforward, managing those patients. The more difficult ones are those without any obstruction to the left ventricle, so they're not cyanosed, they're perfectly normal physiologically. But how do you intervene, and what's the right time to do it? All the evidence is suggesting that the right intervention is a pulmonary artery band.
Pulmonary artery band.
Is their first intervention, because that's
a palliative intervention, or you're talking as a definitive?
Well, it could be anything. It could be palliative. It could be the right preparatory operation to prepare them for double switch. But if we get it right, it may even be that the banding itself is the definitive surgery that they need if we're able to choose the right patients at the right time.
And what is that right patient?
So it's probably before they develop right ventricular failure, but the banding splints the ventricular septum. It forces the septum to support the tricuspid valve and reduces the tricuspid regurgitation. So it may maintain the function of the right ventricle. That's what we're trying to understand, whether that in itself will be enough that they may never come to need a double switch. But at least by banding them, you've prepared them for the possibility of a double switch if they come to need it. And the answer seems to be banding them before 2 years of age are the results that will give us the best possible long-term outcome, whatever route they end up from.
As it stands today, what is the natural history as far as long-term outcomes are concerned after intervention? After intervention, I mean,
if you take the
I won't call that a natural history, sorry, I take that back.
At the moment, it looks like about 80 to 85% survival at 20 years for the entire group of patients. And that includes the really sick patients who may come even as an infant with severe congestive cardiac failure, severe tricuspid regurgitation, which even on a ventilator, on inotropic support, when they come to their definitive surgery. So looking even at the most difficult high-risk patients and putting them in the whole group I say 85% survival at 20 years seems to be what we're looking at. And we hope with better patient selection, in fact we talked about perhaps being able to ban patients earlier, we may even be able to improve on them. And that compares to natural history, probably 40% survival at 20 years is the best possible.
40% at 20 years.
Yeah. It's very difficult to tease out because so much is confused by the data where you don't have an even playing field. We don't see the whole population from the time they're born to the time they have intervention. We see series that are here, there, and everywhere. So I think that's probably pretty accurate estimate of the natural history.
Is LV a concern in the long term in these patients?
Yeah, I mean, for sure. That's the thing we've become most intrigued by, is the long-term function of their left ventricle when you restore it to the systemic circulation. And it seems that there's a group, maybe 15-20%, so about a fifth of the whole population have a double switch, who run into trouble 20 years later with the left ventricle beginning to fail. But it seems the majority of them are patients who are banded too late. That's what we're learning. Either not banded smartly enough, we didn't do it right, or we waited too long. Yeah, and it seems that there's a plasticity in the way that your ventricle responds to a band when you're very young that you don't sustain when you're older. So it seems that being able to band earlier, those patients may well stay free from left ventricular failure, forever.
Now for those patients who at the end of 15 or 20 years when they fail, what are their transplant options?
On the whole, they're a good transplant option because on the whole, usually physiologically, they're usually well. Otherwise, they don't tend to run into trouble with renal failure, liver failure. They don't seem to have a risk of pulmonary hypertension. So, in a sense, even if they are starting to run into failure, they should remain good transplant candidates. Some of them may have abnormal situs, meaning their veins and situs are the wrong way around, which may mean a little bit more thought when it comes to plumbing in a new heart. But most of those things are surmountable, so they still remain pretty good candidates for a transplantation even after they've had a double switch. But the other thing we're learning is that some of the problems we've seen in terms of ventricular dysfunction are related to rhythm, and the resynchronization with biventricular pacing in some cases has been dramatically effective in restoring them back to normal function and hemodynamic practices as well. So there may yet be things you can intervene with before they end up in a transplant group.
So, well, ladies and gentlemen, rather a complex set of disorder with a very poor natural history, but as David said, some of these selected patients could have a very good natural history, but if you select them early, intervene them early and in time, then you can get very good long-term results, and the future looks reasonably bright because transplant options are very much open for these patients with well-preserved other system functions. So thanks a lot, David, for sharing your thoughts, and I hope you have a pleasant stay in India.
Thank you.
Thanks a lot. How many minutes is that?